Well, I am, for those of you who don't know me, I am Krista Harrison. I'm an associate professor here in the Division of Geriatrics, and I am delighted to present our speaker today, Dr. Cheryl Phillips. She is the president and CEO of the Special Needs Plan Alliance, which is a national leadership association for special needs and Medicare Medicaid plans serving vulnerable adults. She's also a fellowship-trained geriatrician whose clinical practice focused on post-acute and long-term care. Many of you locally may know her from when she served as Chief Medical Officer at Unlock, the founding PACE program from 2007 to 2011, or from her roles as past president of the American Geriatrics Society, American Medical Directors Association, or the Society for Post-Acute and Long-Term Care Medicine. She spent the last 13 years involved in health policy to improve and transform care for older adults. And fundamentally, like all of us, her work aims to improve and transform care for older adults. So we are just delighted to hear more about this journey and all the amazing work she's been doing. So thank you.
Oh, Krista, thank you. And thank all of you. This has been a fantastic day. I wish it was in person. I have to say, seeing every one of you was just an honor and treat. I got to see old friends and I got to meet new ones. And most importantly, I got to learn a lot from each of you. So this is, without sounding too gratuitous, such an honor for me to be part of this evening and having spent this day. So I'm going to switch to sharing my screen, because isn't that what all good presenters these days do now with our world of Zoom. So we're going to start with, my focus is going to be on looking at health policy and the intersection with geriatric healthcare. Many of you know a lot about health policy, so I'm not trying to be presumptive that I'm giving you answers you don't already have. But I think for many of us, I know as I struggled early on, both in my fellowship and early on in clinical practice, was I knew rules about certain settings, but trying to pull together the pieces to have a broader view of health policy and care for older adults, but also to understand what my role and where my influences and areas of impact would be. So hopefully those are some of the things we're going to talk about. But probably the biggest thing is that I should put in an intersection of health policy. In this country, we have a health payment policy. And so many of you heard me say this as I talk throughout today. It is form follows finance. And in many ways, that is what drives our health policy in this country. I am the CEO of the nonprofit Special Needs Plan Alliance, as was mentioned, but I don't have any other financial conflicts or interests to disclose, no related stocks, and we will not be talking about any off-label products. So there we go. So stepping back a little bit, as I mentioned, geriatric care delivery right now is very much a cacophony. It's a cacophony of lots of payment models that are being tested. Several of you had asked me about some of the CMMI models. Part of the problem is that they're difficult to scale. Some programs are investing in them, others start them and stop them. And if you are a clinician in an environment, it's really hard to know even the acronyms of MSSP or ACOs, or now the new direct care or the direct contracting entities, DCEs, because they're all driven by a cacophony of value-based / risk-based strategies. And much of that quote unquote value is truly driven by what are the revenue streams and the alignment of the return on investment, whether it is private equity dollars or even government programs. So let's look, first of all, several of you asked about Medicare Advantage. Is everybody going to be in Medicare Advantage? I dare say that if CMS had their choice, they probably would be, because it shifts the risk away from the public entity into the private entity. But right now, as of 2022, 48% of eligible beneficiaries are in a managed Medicare or Medicare Advantage plan. By next year, it's expected to tip over 50%. It's probably worthwhile to acknowledge just the differences out there between, excuse me, the for-profit and not-for-profit plans. Look at the difference. Right now, the majority of managed Medicare is in the top 10 national programs. The not-for-profit plans represent about 4.4% of the enrollment. But overall, the not-for-profits tend to have higher star ratings, which is kind of an interesting phenomenon. They have less margins, but they tend to have higher patient satisfaction and higher star ratings. So what are driving behind this? Well, obviously the growth of Medicare Advantage overall, and clearly this is a bipartisan issue. Although we have lots of tensions going on in Congress about Medicare Advantage, both sides see a value to it. The ours see it as an opportunity for private industry to manage something that they think perhaps the government doesn't do as well. The D see it as an opportunity to better coordinate care and to enhance benefits. As states are moving to managed long-term services and supports, and I apologize for the acronyms, but managed long-term services and supports, those are the Medicaid benefits that we often think about as home and community-based services, those services outside of the nursing home for people who have functional support needs. The states are rapidly moving to managed LTSS, and California and CalAIM is a great example of that, in part because they don't want to have to manage the budgets. These are very difficult budgets to predict. Needs change and shift by population shifts. And so part of the interest of state legislatures is here, let's send it to a managed Medicaid plan. We'll figure out a per member per month capitation, hopefully, and we'll see how that works. There's certainly an increase, and you will see this nationally as well as the state. CalMedi Connect is a good example of this, of integrating services for high-risk populations. Integration right now typically means integrating Medicare and Medicaid, or in California, Medi-Cal. But I think we all know as geriatric health professionals that integration goes beyond to policy and payment models. It's also integration of the whole needs of the person, not just their diagnoses, but what are their functional support needs, what's their behavioral health needs, who is their caregiver support network, do they have housing, do they have access to food? So as I have been thinking in the Special Needs Plan Alliance realm, when we talk about integration, it's bigger than Medicare, Medicaid, but much of the state policy work on integration right now is aligning Medicare and Medicaid. And then came the flexibility of benefits. And the flexibility of benefits, I know that, so I will date myself being a geriatric fellow in the 80s. You know, all we could do was Medicare aligned healthcare benefits. CMS came out in, I think it was 2017, and then further expanded the supplemental benefits so that they're no longer strictly aligned to primarily health related, and they can be targeted by different populations. So this has given some additional momentum for Medicare Advantage plans. I will say some of the most common supplemental benefits that many of you are familiar with are hearing, vision, and dental benefits. So MA plans can add those, whereas fee-for-service Medicare does not have access to those. There's not new money. Those monies come out of how plans bid for their payment from CMS. And so when you take their bids, if there's some money saved from what the average is in the region, and you add the quality bonuses, that becomes their rebate dollars, and that's what funds supplemental benefits. They are not guaranteed money year after year, they change. Furthermore, health plans tend to shift what they're investing in for supplemental benefits. And so they give an incentive for Medicare Advantage, but they have a hard time creating a consistent platform. Right now, MedPAC, the Medicare advisory group that advises to Congress are starting to think about, can we have some standardization of supplemental benefits, at least some definitions and some equal services. But I think even that's going to be hard given how supplemental benefits are paid for. So we know that fee-for-service, I won't spend a lot of time on this, but fee-for-service was never an ideal model for older adults with complex care needs. The obvious incentive is by specialty to drive interventions and procedures. There's really no mechanism to coordinate. Even alternative payment models such as ACOs have a limited impact on the coordination aspect between services. Much is driven by diagnosis, setting of care, and the provider. And there's nothing in Medicare that serves to coordinate home and community-based services under fee-for-service. And rarely outside of a geriatric model is functional status ever adequately included, not only in the diagnosis, but in the treatment plan and in the overall coordination for the individual. So then we bring in Medicare Advantage, and Medicare Advantage by its simple nature is also not a panacea. And I know we talked about this with some of the fellows that, there is really a push, as we've mentioned, for Medicare Advantage, but most providers within Medicare Advantage, so when I say providers, doctors, hospitals, nursing homes, with the exception of probably some of the areas in California, most Medicare Advantage pay the providers a form of fee-for-service. So it's not like it has transformed the delivery system on the provider side. California and some of the other more advanced areas with managed care, some areas in Florida, Minnesota, they're now looking at delegated models where the health plan delegates the risk to the physician group or the hospital system or the healthcare system and says, we will pay you, we're going to take our amount off the top, and then we're going to do some other things behind the scenes, but we'll give you X amount of dollars per enrolled member per month. And then you're required to meet quality measures, but still the wins end up being in reducing hospital care and reducing overall acute care costs. That's what drives the money saved, and the money earned is driven by diagnosis codes, which increase the risk adjustment factor or RAF score. Those of you that work in a managed care environment know well that you need to code every single diagnosis. You need to get the HCCs out to the 4th and 5th decimal points because you need to maximize the risk adjustment. Many of the payment models from the Medicare Advantage plans are actually incentivizing providers and docs to increase their diagnosis codes because it means more money to the plan, which means more money to the healthcare system and to the providers. And so often their quality bonuses are tied into increasing codes. And now under some of the delegated models, some of the bonuses are also tied to, in addition to utilization management, star ratings for the health plan from NCQA. And I think most of you, the health plan NCQA star ratings include HEDIS measures that I know you are very familiar with, as well as some other patient satisfaction and medication adherence and some other measures that are tied into what is deemed as quality. The problem is this quality measure doesn't necessarily look at the unique needs of subpopulations, and we'll talk more about that later. So the ongoing issues with general MA, again, as I touched on, there's little to no coordination. There's not necessarily an incentive for long-term supportive services or home and community-based services. And you and I all know that older adults are not the sum of their hierarchical condition categories. The sum of their diseases is not the holistic need of what their person-centered needs are. Rarely do the HCCs take into account for functional status. And benefit is really hard to measure, particularly in short term. So what are we doing? What is the value in the value-added programs are often struggled because health plans have a limited time frame. It's hard to have attribution. ACOs are really struggling with this. So if you are a primary care doc and you are in a larger specialty network, the attribution to whom for what becomes a very difficult problem. And then we'll talk a little bit about appropriate measures and risk adjustment, given that we are not even measuring what means quality for many of these populations. HEDIS measures we know fall very short with people with very severe complex comorbid conditions, or who are very functionally impaired, who are maybe at the near the end of life. So MA plans are starting to learn, and this I'm going to put in a plug for geriatric health professionals, that they're starting to learn that this is an important arena for having good geriatric approaches to care. And I like to look at it as the secret sauce. Again, this isn't new news to you guys, but a population-based focus, integrated policies that reflect across settings of care, so that we're not siloed by the hospital, the nursing home, the outpatient, and that it's all focused and funneled through geriatric principles of care. That's the optimum delivery model. Is managed care the best vehicle? Probably. It's not there yet, but there's some certainly leveraging that's going on that brings this secret sauce process down. So we're going to get into some of the current literature on Medicare Advantage, because as we know, MA by itself is not nirvana. And I'm not here to either promote or to disparage Medicare Advantage, but there's been a lot in both the lay press as well as policy discussions. First of all, there's a lot of criticism focusing on mining for diagnoses, whether it's through home visits or through specialized clinics that just do annual assessments to make sure that all of the codes are captured. If that code is not being linked anywhere in the care plan or chart to a service or intervention, CMS is starting to go through these in audits and say that's fraud. You can't put in a diagnosis that you did in a home visit just to capture diagnoses on an annual basis without having any link to some sort of service or care related to that diagnosis. So having said that, there's a health affairs blog that Gil Fillen and Don Berwick, Don being the former CMS administrator, said, you know, in and of themselves, MA plans are not necessarily giving a whole lot of value to beneficiaries. Merely having a capitated model which drives increased coding but is not linked to enhanced services is not improving the outcome related to their costs. Remember that the costs right now for MA are slightly higher than fee-for-service because the coding is much more effective. So when CMS created the payment model for Medicare Advantage, it assumed that all the average Medicare beneficiaries were a cost of one. And because MA became very efficient at capturing codes, which fee-for-service plans did not, the MA plans have been incrementally increasing their payments to where they are roughly 15% higher, 15% higher than fee-for-service. And so now the alignment to that one being the average is no longer working well. And MedPAC, again, the advisory group for Medicare to Congress, is we're currently saying that we need to adjust coding intensity. We need to shift the normalization factor. And I won't get into all of the payment issues, but basically they're saying we're paying MA too much and we're not seeing a difference because of it. And I've given you resources to where some of these points are. And then in New York Times, because the lay press said, well, we got to get in on this discussion as well, that they referred to New York or to Medicare Advantage as the cash monster, that because of the coding, it's not necessarily linked to better care. And I think there's a lot of tension back and forth. I think one of the things that MA plans are going to be seeing, certainly starting next year, is increased focus on audits so that there is a linkage of the services tied to the codes. So does Medicare Advantage actually make a difference? The Kaiser Family Foundation, which is a wonderful policy group, and those of you that are interested in having a very digestible source for policy, subscribing to the newsletter of the California Family Foundation and looking at their blogs and their reports, even if you just Google KFF and doing a little bit of reading, they're a wonderful source of policy summaries to give you an idea of what's happening in Medicare and health policy at large. So in their assessment and their review of claims, that Medicare Advantage beneficiaries were more likely to get routine checkups, they were more likely to get immunizations, while those in traditional Medicare were more likely to receive care in highest rated hospitals. Of course, we can also argument where's the rating coming from. But in the roles of satisfaction, or the rates of satisfaction, were similar to both groups, which is an interesting outcome, I think. And this is was published September 16 this year. So let's now take a step back and say, okay, so if general MA is sort of doing the same thing as fee for service, they're not a whole lot better, they're probably not a whole lot worse. They're getting more money. People are getting more supplemental benefits. That could be good. But how are we looking at the needs of that subset of high risk, complex need Medicare beneficiary? So out came the special needs plans. Special needs plans are a type of Medicare Advantage. So the beneficiary has to qualify for Medicare, and they have to meet specific criteria to enroll. They were first offered in 2006, and they were made permanent under the Balanced Budget Act in 2018. They're available right now in 47 states and the District of Columbia, and over 4.2 million people are enrolled in special needs plans in 2022. There's a lot of nomenclature here, and I'm not expecting you guys to be experts in special need plan acronyms. But because this is also an important issue for California, I think being familiar with the types and what they mean is critically important. So there are dually eligible special needs plans. Those are individuals who are Medicare and Medicaid or Medi-Cal eligible. Underneath that, there are two subtypes because CMS will never leave an acronym alone. So we have highly integrated or HIDE SNPs and fully integrated or FIDE SNPs. The one unique thing about FIDE SNPs is that they have to cover 180 days of nursing home care. Right now, the only FIDE SNP in California is the SCAN Health Plan because the carve out of home and community-based services with IHSS and also the carve out of behavioral health. Institutional SNPs are those special needs plans targeted at individuals who are at an institutional level of care. In California, that's nursing home level of care with 2 or more ADL deficiencies. You need not be in an institution, you can be in the community, but most I-SNPs either focus on nursing home settings or congregate settings like assisted living. Then there's chronic condition SNPs, where you are eligible as a Medicare beneficiary if you meet one of the 17 diagnostic categories or combinations of, and we'll talk a little bit more about these later. All SNPs are required to have a model of care. This is actually a very important thing that is different than a general Medicare Advantage, which says how is a plan going, who are they going to serve, how are they going to serve this population, how is the network being developed, how are they training providers. So let's say if you have an I-SNP plan, who are you working with, who are the providers, how are you coordinating care with them, and all of this. And there's multiple aspects to a model of care that then has to be approved by NCQA. Special needs plans also have to have 3 additional quality measures, including a care coordination and a pain management measure. They have to have an annual health risk appraisal, which has been criticized as one of the sources for increasing codes. But the special needs plans, the intent is that this health risk appraisal be tied into the individual care plan and used to coordinate services. D-SNPs have to integrate long-term services and supports and behavioral health. In a highly integrated D-SNP, it's when the parent organization has both the managed Medicaid and the managed Medicare, but they're not necessarily an overlapping population. And a fully integrated D-SNP, they are fully integrated in that the parent organization, let's say iCare Health Plan, has the managed Medicare and the managed Medicaid with long-term services and supports and behavioral health all in one plan. So it starts to look much more like a single source for the beneficiary with a single card, a single enrollment process, a single point of contact. And now D-SNPs have to have an enrolled member advisory committee. That is still being rolled out this year with lots of questions from the health plans. But basically it says you have to have an advisory group that is comprised of those individuals who are enrolled in your plan as a representative. So just a little bit of numbers. D-SNPs are by far the greatest. They're over 3.5 million. C-SNPs are just under 500,000. They're a little over 400,000. I-SNPs are the smallest group, about 96,000, and MMPs, Medicare Medicaid plans, or the federal alignment demonstrations in California. That's what CalMedi Connect is transitioning into D-SNPs. So the MMPs are actually going away in 2025. In California and New York, they're going away much quicker. And in California, they are going away at the end of this year. So a little bit focused more on D-SNPs because that's a lot of what's going to be happening in California. Many D-SNPs began as coordination only, which meant that they didn't really have any ownership on the Medicaid benefits. They just tried to coordinate them. I can tell you this varies greatly across the country. There has been no standard, and there's been a lot of frustration that D-SNPs by themselves didn't do much to change the care for those Medicare beneficiaries who were duly eligible. Since 2018, with the new rules, there have been more aligned D-SNPs. That's the highly integrated and the fully integrated. When you look at some of the D-SNP data, 30% of all duly eligible individuals are enrolled in a D-SNP. The majority of those are in coordination only right now. Only about 11% are in aligned plans. And that's starting to change across the country, and certainly California, as they're rolling out the new plans for CalMedi Connect, are looking to move as many people as possible that are duly eligible in a D-SNP plan into a fully aligned integrated D-SNP plan. D-SNPs do tend to overrepresent persons of color, as opposed to 46% of duals overall. So D-SNPs have a higher proportion of persons of color. Highly integrated, I won't go through all of this. This is really meant to be a resource for all of you, but this starts to look at the alignment of Medicare and Medicaid under a plan and some of the grievance processes, but most important, the coordination of services. And I want to go back to long-term services and supports. Those are the Medicaid benefits, home and community-based services, and behavioral health services. In California, that creates a problem because by state legislation, it is carved out for behavioral health, and LTSS is carved out predominantly at the county level. The state is trying to think through with CalAIM how some of those bridges can be managed. So the CalMedi Connect is transitioning. That's the MMP demonstration plan to the CalMedi Connect model, which will be integrated, exclusively aligned D-SNPs and all of the things that we talked about. And there's a wonderful link for those of you that really want to get immersed in what's happening with the Department of Healthcare Services in California for those duly eligible. This is a great resource, but you know, get a glass of wine or a nice warm cup of tea because you'll be reading it for a long time. A quick look at the other two SNP types, chronic conditions, one or more groups of the 15 serious conditions. Eligibility is verified by the medical provider. So physician, nurse practitioner, you just need to write in the note in the diagnosis that they have one of these conditions. CSNPs can enroll people who are dually eligible, and they can contract with Medicaid plans, but they're not required to coordinate. So a really good example of a CSNP in California is the AIDS Healthcare Foundation. They exclusively enroll HIV/AIDS individuals. They do contract with Medi-Cal plans, but they themselves are not coordinating under the CSNP model. And then the institutional special needs plans at an institutional level of care for at least 90 days need not to be in the nursing home. So there is the institutional equivalent that I made a reference to. And while most people in nursing homes after 90 days are dually eligible or dually enrolled, there's no requirement to coordinate them at the Medicaid or at the state level. So some states are starting to push back somewhat on ISNPs because the distrust is that ISNPs have an incentive to keep people in the nursing home or at an institutional level. ISNPs are certainly expanding within California, and it'll be interesting to see how California handles both the ISNPs and the CSNPs for those who are dually eligible as they roll out CalMedi Connect. That's yet to be resolved. These are the criteria, the diagnoses. Interestingly, so there is dementia as one of the diagnoses, but there's only one plan that has a chronic care dementia, because unless you have access to the long-term services and supports, remember the chronic care SNPs are the Medicare only, you're really not able to do much managing for these individuals, because what you need to do is coordinate support services in order to save money on the Medicare side. So that's why the dementia program has not taken off. Congress had reached out to a number of us to talk about what would it take in order to expand dementia. And part of the answer was you need to add services and supports payment into the Medicare structure, either under a demonstration model, because if they don't have Medicaid, then the near duals or lower income Medicare beneficiaries who don't have access to Medi-Cal or Medicaid, there's nothing that the dementia plan would be doing unless you had some coordination of benefit. Unfortunately, Congress was not interested. We were suggesting a $400 per member per month add-on for services, and anything that meant new money didn't go very far. But I don't think it's too surprising, these other chronic conditions. So how does SNPs work for older adults, and why does it matter? And I know this is a little bit busy slide, but we talked about targeting, having specific measurable goals in the model of care, understanding how the interdisciplinary team works, doing the risk assessment that ties into the care plan. All of these things build a support network that allows the plan and providers to work much more closely than they do under a general MA or certainly under fee-for-service. It also allows the plans to do a little bit more with supplemental benefits for the chronically ill. Again, as we mentioned earlier, there's no new money, but it allows the plans to be a little bit more creative. So one of the more popular supplemental benefits is additional in-home care, also transportation and meals beyond just a post-acute 30-day meal program. So plans are starting to be creative in how they can coordinate these benefits for targeted populations. So what I really want to get at is to step back and think about, so what does this mean for healthcare professionals in geriatrics? What is our role? We'll talk a little bit later about our role in policy, but I think we start with even understanding or advocating, how do our health plans even share information between setting? Are the health plans paying only by setting and provider type? Are we looking at meaningful goals-based care planning and advanced directives? How does reimbursement work beyond RVUs and other fee-for-service payment mechanisms? I was talking with one of the fellows. One of the things that I strongly believe is that geriatric health professionals in primary care should be paid salary with specific quality measures and outcome measures, because what we do is so far beyond just the 15-minute RVU billed office visit service. but how care is coordinated. Yeah, we've got some fee-for-service add-ons that can be coded, but I think that that's one way as we look at payment models within both health plans and delivery systems for geriatric care. And how do we align policy? So this starts to look maybe at our state level. Are we truly integrating the whole person in services, or are we continuing to carve out services by specialty or by payment model? And are payments and services only driven by setting of care? So you get such and such a payment if you're at a nursing home, but you get a different payment if you're at home with home and community-based services. How are we looking at what are the holistic needs of the individuals? Those start to be important voices that geriatric health professionals have at a policy level, at the state and at the federal level, and really moving beyond typical multidisciplinary care to true team-based care, which I like to think of as transdisciplinary. I could spend a whole session just on how do we measure quality? What are we measuring? HEDIS measures fall very short for many of the populations that we serve here. Some of the health outcomes measures, we send questionnaires to people in languages that are not their native language, that they can't read. We have ridiculous questions that say things like, can you still golf? Do you bowl? For many groups, I think of the Somalis in Minnesota, they don't even know what we're talking about, let alone is that any of interest to them. So what we are measuring, how we are measuring quality, to me is so vitally important. And it's not just about risk adjustment, and we're not trying to risk adjust away poor quality, but we aren't even measuring what matters for populations. And we aren't looking at it in a transparent way for consumers to understand what does the quality measurement mean. And because many disadvantaged populations in particularly DSNPs may have lower HEDIS quality scores, they get folded into the larger MA plans that tend to have higher scores. Therefore, there's often very little transparency and meaning for individuals that are trying to select a plan. And right now, I think all the plans are falling very short on how do we support families and caregivers, which become the most important intra-support system along with the provider network and the health plans in meeting the needs of complex care individuals. So what happened in, we had great plans. I'll talk a little bit about federal policy. We had that federal HCBS. Do you guys remember? There was like billions of dollars that Biden put forward in a budget for federal home and community-based services. There was a proposal for caregiver tax credits and family support incentives. And those of us who were thinking, yeah, this is what really needs to happen. And then when all the bills were sorted through, those fell out. Why? Because public and stakeholder support that was very loud had to do with drug pricing and healthcare affordability. These other areas, home and community-based services and caregiver supports and tax incentives, fell out because nobody was speaking out them from the bottom up. And the problem is again, our health policy is a health payment policy, and many of these issues were focused on very narrow issues that had good support from unions. They did have some top-down support, but there was no bottom-up large-scale voice. The fact is that most people, unless they are a caregiver, don't realize what the challenges are. Unless they are trying to take care of a loved one with Alzheimer's or related dementias, they don't know what limitation in home and community-based services are for people who don't have access to Medi-Cal. So we didn't get the upswell that we needed. We haven't given up, but that's a little bit of what happened in the federal side. What's going forward to look at some of our other options, and then I'm going to spend some time for questions, I promise. Lots of demonstrations with CMMI. I guess I'm a little bit impatient with the demonstration mindset because we have a cacophony of demonstrations, but we don't necessarily look at all the outcomes and we don't look at how to scale them. So we have lots of wonderful localized programs. I was part of a CMMI demonstration with Sutter. It was wonderful for the people that we served. Then when the champions left, then the program dissolved. CMMI would like to look at some demonstrations for dementia. And as I mentioned earlier, that's going to have to include some supports for home and community-based services. There's another idea looking at people who are up to 400% of federal poverty level who may not meet Medicaid or Medi-Cal criteria, but who could buy in at a reduced rate for long-term services and supports benefits. That's being weighed with what the cost will be for the states. But some states are very interested. Washington in particular, state of Washington is interested in a buy-in for LTSS. One of the most interesting and provocative areas is a bill sponsored by Portman and Brown. Interestingly, Portman is retiring at the end of the year and was not reelected. He didn't run for reelection. So he kind of threw this out here as a placeholder, but it would be to do away with Medicare Advantage and manage Medicaid for those who are dually eligible and create a brand new title, Title 22 at the federal level. This would create a new benefit structure, a new aligned coordination. Lots of problems with this one because since every state has their own set of Medicaid benefits, if you're going to line it with Medicare under one title, does that mean you're going to have 52 versions of Medicare? I don't think the public wants that. This would mandate that all those dually eligible who wanted managed care had to go into this benefit structure, which may become challenged with some of the freedom of choice requirements that are in statute for Medicare. But it's going to create an interesting conversation. So clearly at the federal level, there's interest in better understanding how to align Medicare Advantage and manage Medicaid. Certainly the master plan for aging, and I put a link here. I'm very excited about that. It is wonderful on paper. I think it has huge potential. The real challenge will be how is it executed? I'll disclose transparently, I'm on the SCAN Foundation board, and we spent a lot of time working on this master plan for aging. And it is becoming a template for at least 6 other states right now. So we're the first state to have a master plan for aging. To me, the ideas are wonderful. It is now the execution. What will it look like? And then a whole array of private capital, private equity in healthcare models. And is that good? Is that bad? I certainly have concerns in that when we're looking at a high risk, high needs population, if private equity is publicly traded and has to pull out revenue back to shareholders, that revenue really should be back into the system because you're taking out Medicare dollars that are tax funded. They should go back into services. But others will argue that without private capital and private equity, we don't have the investment into new models. So that's going to be an interesting area of tension for both Congress and for all of us as we look what healthcare programs are going to look like going forward. Even the PACE program having the role of private equity now and being publicly traded. Lots of end of year lame duck issues. I'm not going to spend a lot of time on this. I just wanted to give it for those of you who are truly policy wonks to get into some of the details. I will say that the telehealth waiver is probably going to continue through 2024. It's not yet passed. It's going to be one of the lame duck, but there's a lot of interest in continuing the telehealth waiver through 2024. And if fee-for-service Medicare does it, then Medicaid will do it. This COVID policy and spending is going to very quickly come to an end. That's unfortunate because we don't know what this next winter season is going to bring. And then you can read some of the other details. So how can you impact policy? That was a question a number of folks had. You know, yes, I put some of these low impact areas all the way to higher impact areas. Low impact form, you know, email forms to legislators. AGS often will send out, alerts, and you can do standardized phone. Social media posts sometimes create noise and discussion. We've certainly seen that around caregiver support. Voting matters, knowing how your candidates stand in particular areas, but they probably overall have pretty low impact. Higher impact, meeting with legislators. I think that's a very strong, it doesn't seem as time consuming as you might think. Setting up, even if you have a day off and going into Sacramento and meeting with a couple of legislators that are focusing on issues that you are interested in, they value that highly because they don't speak to providers very often, and you can have a huge impact. AGS, as you know, has a whole list of activities. Many of you may participate in news and media. That's a way to get public engagement. Writing op-eds for newspapers is another thing to do. It's a high time commitment, maybe a high output, but sometimes not. Engaging in CMS and legislative comment letters, even if it's just a sentence or two. So CMS always posts for public comment. So does NQF. Those are important areas if you're following them to send comment. Every one of your comments are read and taken. They may not always be agreed with, but they are taken into account. And then working with state or federal advisory groups. There's a number of them in California, even the advisory groups with Master Plan on Aging. And the one thing that I didn't add is doing a health policy, even a part-time health policy. There's the health and aging policy in DC that has both resident and non-resident. And if anybody's interested in that, I can happily give you the connection. And then, because there's always fun reading, here are some things to talk about with policy, but this is really meant for a resource. So what I would like to do, first of all, to make myself available, I am very happy to talk with any and all of you, either by email or by phone, because a lot of you have policy questions, or a lot of you may be wondering how you can even frame your own career. So with that, I'm going to pause, stop sharing, and then I think the fun part now is that we can manage some questions. So thank you.
Fantastic. Fantastic. I certainly learned a lot. We do have some questions, so let me read a couple of them. So Todd James asks, how much do the SNPs talk to ADRCs, AAAs to bridge healthcare and social care? Are there models for referral pathways and connectivity?
Yes and yes, and the connection only ones did very little. One of the big, and I'll tell you, this has been my personal push with our SNP Alliance members, is creating relationships with home and community-based services, and also working with some of the conveners. So for instance, in California, the Partners in Caring Foundation that serves as a collaborator between home and community-based services and health plans. The health plans by themselves have to start to coordinate and understand and work with home and community-based providers. Having said that, it is so much easier said than done. So even things like health plans don't know how to contract with HCBS providers. They ask them for their NPI number, and a transportation mom and pop service says, what's an NPI number? I don't have that. The exchange of information has been problematic. So the health plans will complain, we send X number of people for care coordination or for meals programs, and we never hear back. Who got served? How long did they get served? Was there a good outcome? All we know is that we pay the bill. The community-based services will say, all we get is a list of names. We don't know necessarily how to outreach to them. We don't have a fluid conversation of what needs are, and we don't have anybody to talk to on the plan, even if we did have information to exchange. So one of the next steps is, how do we have meaningful informatics exchange that, yes, is HIPAA protected, but this is also under TPO. So it is treatment payment operations protected under HIPAA. And particularly if the recipient of services gives permission that we can start to share information. So it's starting to crack open. I will tell you one of the shortcuts that I'm not sure is the long-term solution. There's a number of app-based referral programs And they're saying, okay, health plan, you give us a data dump of all of your people and we'll sort through it and we'll figure out who needs what services and then we'll coordinate them. And, surprisingly, the individual doesn't necessarily trust when they get an email or a text from some service that's app-based that says, don't worry, we're going to solve all your problems. So the warm handoffs, the information exchange, plans working locally with home and community-based services is absolutely essential. And DSNPs are starting to do that, but boy, it's a journey. I don't know if that answers.
Yeah, I think so. It just made me think about how older adults, how do you advertise this or help people understand? And how do people know what's the best plan or what they're eligible for? How does that all work?
And that's another huge area of work. Right now, the number one connection is through brokers. Now, if any of you have brokers in your family, I don't want to disparage them because they're well-intended, noble individuals, but they're not looking at it through the lens of what the individual needs. Frankly, they're looking at it from where their contracts are and who's paying them for referrals. Then there's the SHIPS programs. In each state, they have the health insurance Medicare advisors are usually volunteers. As I have talked with number of the SHIP coordinators, they don't even know what SNPs are. They think it's a kind of haircut. And so they don't know how to. And then if you go to, the plan finder on the Medicare webpage, oh, God help you if you can navigate that one. But it will have up in the corner, are you interested in the special needs plan? I have to say most beneficiaries have no idea what that is and are not going to click on that box and don't even know what the plans are when they get there. So the challenge of creating networks and outreach and information. So I'm not saying that every Medicare beneficiary needs to be in a SNP plan. They don't. And for some people, they've created a good network, even if they have complex needs. But most people aren't given the information and access to knowledge. So that's another thing that we're trying to work on the CMS side. And it's something that I think the states can play a big role in.
Right. And this was a comment based on the prior thing we were just talking about, data sharing. Says, just in alignment to Todd's question, San Francisco ADRCs are challenged with patient information sharing secondary to HIPAA. They've asked the city attorney's office for policy guidance, but to date, it has been silent. San Francisco ADRC state this is a significant challenge.
It is a huge challenge. And I will also provocatively say HIPAA is less of a challenge. HIPAA regs are not the challenge, it's HIPAA myth regs. And it is really hard to get past HIPAA myth regs. So there are mechanisms for health plans to have releases of information. There are platforms that are HIPAA protected that can be information exchanges because they're related, particularly when there is a TPO contract of, I won't get too much into acronyms, but the treatment payment operations contract between the payer and a provider of service. That's an allowed HIPAA information sharing. But we have so many barriers about perceived HIPAA regs that we don't even get down to actually resolving what those are. And yes, in San Francisco, in LA, and throughout the country, some jurisdictions have done it better than others, and I think that they are good laboratories, but that's a huge area of work, is helping to understand how can information be shared in a private, safe, protected way that meets the beneficiary's needs. And it's not just the ADRCs, it's not just the AAAs that have this responsibility, it's also the health plans that need to be part of this as well.
Great. Another question is, it seems likely that so many specialized payer models might have effects on the health industry workforce. What are some of the workforce issues or constraints or opportunities that you're seeing?
Yes, and yes. And first of all, we know that workforce is a crisis foremost.
Mm-hmm.
The biggest workforce crisis is probably for those with the highest needs, and that is direct care workforce, CNAs, home care workers, all the ones that we don't pay very well, and we expect them to do a lot of things. And I think that health plans have, to quote my delightful Southern husband, they have a dog in that fight. Health plans should be part of the solution in some of the workforce challenges, but it is complex. It's also tied to immigration policies, which are also complex. So there's a lot of politics. But getting back to kind of the essence of the question, I started with that slide of the cacophony of payment models. And each one of these payment models is trying to snag a provider group, a workforce that can work for them on that payment model. And it's a finite group that's out there. Now, I will say that is given some expansion of career options for geriatric health professionals, because we are now very highly in demand. And Louise, you gave me a wonderful example of even within UCSF of now, 15 years ago, what's geriatrics? We all take care of old people, to now everybody wants somebody with geriatrics expertise in their domain. And that's also playing out in all of these payment models. They all want someone with geriatrics knowledge, either in the C-suite, overseeing clinical models, setting up payment models, doing direct care, managing primary care. So is it good for us in geriatrics healthcare? Absolutely, because it gives us a lot of career options coming forward. I think that the challenge, though, is we can't just have segmented payment models that are doing isolated things and pulling off workforce to meet one particular payment need. Again, we have a health payment policy, not a health delivery policy. And, that's part of our work. So I know every time you ask a question, I end up posing bigger problems related to it rather than posing solutions, but these are all incremental steps. I still think we're further along than we were 15, 20 years ago, certainly 35 years ago when I finished my fellowship, where there was very little options for creative service delivery, but we're a long ways away from finding the answers. Although I think anybody who's coming out with a healthcare professions background in geriatrics, you're going to have a lot of opportunities.
Yeah, I agree. And I was just reflecting, you had a great slide about how can I impact policy and just the different options. I mean, how does one go about getting on like a federal advisory board, or do you just email your legislator if you want to meet with them, or what's sort of the steps
so I
for
got
that?
on. So again, the world is not all according to Cheryl, but I was disgusted with nursing home quality in the late 80s when I finished my fellowship. And so I started writing to legislatures and I started testifying. And then I got put on a quality oversight group. I reached out because of my interest in home and community-based services and reached out to the then director of Medi-Cal, then it had a different acronym, but DHCS, and said I would really like to be on the Olmstead Commission. And she said, oh, we don't have a doc and we could really use a geriatrician, so that would be great. But I also was in a position where I was salaried. And part of my argument to the healthcare system was, you will get more out of me, both at a policy level and at an oversight and even my direct patient care, if I am paid by salary, not by productivity. So part of the challenge, because I don't want to be trivial, if you're in a group practice and you're working for a large healthcare system that says you have to see X number of units per day, because people are now units, it's really hard to break out time to do some of these other things. So creating a value statement to the organization in which you work can also be a huge asset to allow you to do some of these things. But yes, don't be afraid to reach out. Legislators would love to meet with you. Even if you sent a letter or an email, the impact that you will have is remarkable because they're not hearing enough from providers. Who knows, you could even run for office and change the world.
Well, I think that's a great place to end.
Yeah.
Very inspirational.
I
So
just want to
again,
say thank you so much. This truly has been an honor. You guys are all my heroes, and what a great day this has been, and continue the fantastic work you do. And if I can answer any questions offline, feel free to use my email. I'd love to be a servant to all of you. Thank you.
fantastic. Very much appreciated.